this case, because you will see several specialty that will be involved. Why is it going to bring headache? Because you have to sample it. Because the importance of the hamartoma does not really come from the fact that it is a hamartoma. Rather, actually, it comes from the fact that it will go into the differential diagnosis, with a malignant tumor. In this case, that's really, why you would really worry about, benign tumors, for the most part, is the fact that they will go into differential diagnosis with malignant tumors. In this case, they will go into the differential diagnosis with the adenocarcinoma that is known actually to arise in the peripheral aspects of the lung. So in this case, you have to sample it, and what you're going to be finding is exactly the same tissue that you find in the lungs, which is cartilage and bronchial glands, and a little bit of stroma here and there, but they are not arranged in the normal way. So you will not see them forming actually a bronchial, epithelium. They will not form bronchi. They will not form, the bronchial glands that are present in the wall of those, bronchial epithelium. So in this case, what you call haphazard data arranged in a very disorderly kind of fashion, but it is benign and it belongs to the site where it is arising from. That's what you call a hamartoma. Again, importance comes from the fact that it will go into the differential diagnosis with the with the malignant tumors. Now here's another example of a tumor-like mass known as a choristoma. In this case, it is benign tumors, benign cells, but they do not belong to the site where they are arising from. For example of that, the very common example is the presence of gastric pancreatic tissue in Miguel's diverticulum. So that's when it should not really be there, and that's really going to open a lot of complications for this patient. So from the from the tumor's point of view, it will not really matter that much. Why? Because it does not form, it does not going to be metastasizing or invading because it's benign. But because of the fact that it is arising where it should not be, gastric, especially if it has gastric or pancreatic, cells that are, still active, they are going to be secreting, the HCl, right? Or actually the very powerful pancreatic enzymes that are going to wreak havoc on the intestinal wall, and they may actually perforate, they may result in, peritonitis in this patient. Here's another example, salivary gland choristoma of the middle ear, when you start to see elements of salivary gland in the middle ear. Again, benign tissue that is present that does not belong to the site where it is arising from. Now, benign versus malignant neoplasm. How would you decide if the tumor that you are dealing with is benign and malignant? We did talk about actually the behavior of the tumor last time. I mentioned to you that probably this is the most important, or one of two, important features to differentiate, or criteria to differentiate between benign versus malignant. So, you may depend on appearance of the tumor or behavior of the tumor. And how do you do that? You have to actually go through those 4 criteria to decide what you are dealing with: the differentiation and the anaplastic, nature of the cells, the rate of growth, how fast is the tumor growing, is it invading or not, is it giving rise to metastasis or not. Now, you will see that there's what you call golden kind of criteria. For example, metastasis, when you say the word metastasis, that's a malignant tumor. Really, whether medical school or pathology practice, metastasis is definitely a malignant tumor. Again, like, you remember the 0.101 percentage where you see a benign tumor that may be actually metastatic, but that's not really to learn from. That's the exception to be always on the lookout for, but it is so rare, it will probably never happen in anyone's lifetime. The other criteria, you will see that it's really what you call a lukewarm kind of criteria. For example, locally invasive. Some benign tumors are actually, locally invasive. They may result in nearby destruction. You see them in year 3, inshallah, or you will see them in year 3, inshallah. That's called, for example, the giant cell tumors of the bone, known to be very powerful kind of benign tumor, that may actually result in local, invasion in the form of local destruction, going through the bone, destroying the bone, hollowing it out. But at the end of the day, for the most part, it will never metastasize. So you can see actually, the limitations that are put on a benign tumor versus that of malignant tumor. Rate of growth, that's really what you call again, a lukewarm. It's not really a very solid one. For one, because you don't really follow the tumor day to day. That you're going to be seeing it in 5 years or 10 years. And as a result of that, you may not actually depend on it, from the diagnostic point of view, but from the biological point of view, the rate of growth of a tumor is going to be very different between benign versus malignant. We will see that the malignant tumors have a very incredible ability to grow very fast, and to give rise to a larger mass, far more superior to that of a benign tumor. And then differentiation and anaplasia, we'll talk about that now. So we did talk about differentiation, and I did mention to you when it comes to the word differentiation, you use it only with malignant tumors. Why? Because benign tumors, by definitions, are well differentiated. So you never even say the word well differentiated benign tumor. That's a no-no. But when it comes to malignant tumors, you have to compare the tumor cell to the site of origin and decide, does it look exactly the same? Does it look nowhere near the original site, or is it somewhere in between? And that's going to decide if you're going to be calling it well differentiated, poorly, or moderately differentiated. And the reason why you're doing this, because you may actually link this criteria to the behavior of the tumor. It is known that well differentiated tumors are going to behave very well, as opposed to poorly differentiated tumors that are going to be very aggressive tumor in the most number of cases. Moderately differentiated, again, lo and behold, it will be somewhere in between very aggressive and very well behaved. All right, so now when it comes to anaplasia, again, as I mentioned to you, talk about dysplasia, you take anaplasia and you go a step higher. Again, what's dysplasia and what's anaplasia? At the end of the day, all of them are actually going to be cancerous cells. But the anaplasia is going to give you peace of mind. Why? Because when you say anaplastic looking cells, it cannot be in a benign tumor. Okay? Like I said, dysplasia, usually it is what you call a wishy-washy kind of thing. There are people who believe it is actually absolutely malignant, and they equate that to cancer. There are others, the academicians, who think that it could be reversible. But if you talk about anaplasia, there is no way that this could be anything except a malignant tumor. Did you see what I'm saying here? So dysplasia, there are two opinions, if you will, right? But when it comes to anaplasia, that is absolutely one-way street, and that is a malignant diagnosis. So what are the features of anaplasia? The same features that you have seen with dysplasia, but slightly worse. So the NC ratio, for example, will be much higher. The nuclear and cellular pleomorphism will be also much higher. The hyperchromatic nucleus, the prominent nucleoli, abundant and atypical mitosis, tumor giant cells, all of those are features that you may see dysplasia, but you see that more abundantly and more actually higher grade than that in anaplastic cells. All right, so again, why are you looking out for anaplasia? Because again, the connotation is going to be linking it to behavior. When you say anaplastic tumor, you are saying that this is a very aggressive tumor. By definition, this is a very aggressive tumor. Here's an example of that. So there is what you call, your garden variety malignant tumor, and then there is, the most severe form, if you will, of the dysplasia. In this case, that's in the form actually of these tumor giant cells. All of those were actually single cells at one point in time, but they started to fuse together, giving rise to this tumor giant cells, malignant tumor giant cell, as you can see here. You can look at the size of the nuclei. So if the garden variety, if the usual, if you will, size of a dysplastic cell is this big, the anaplastic cell will be at least, probably, 5 to 10 times as big as that. Now look also at the nuclear membrane irregularity, pretty irregular nuclear membrane compared to what you see with other, less, less poorly differentiated, more differentiated tumors, malignant tumors. Okay. So here's an example of actually abnormal mitosis, what you call a star-shaped mitosis. With more aggressive tumor, with a higher grade tumor, if you will, more poorly differentiated tumor. In terms of mitosis, you see that the cells may actually have all kinds of mitosis. It may be star-shaped. It may actually be a smudge cell. smudged. The whole nucleus will be smudged. You cannot really tell them apart. Why do you think this is the case? Why do you think that in malignant cells, especially in more like high-grade tumors, you will see very abnormal shaped mitosis?
Fast.
Cytoskeleton is not properly formed.
Cytoskeletal what?
Cytoskeleton is not properly formed.
No. This is actually a cell that is undergoing mitosis. This is what happens. When they are undergoing mitosis, that's really what's going to happen. That's why you call it abnormal mitosis, right? So why is that the case?
Maybe there is.
Could it be dividing into more than 2 cells at once? Is that possible?
No.
Due to the damage to the DNA.
Excellent. So exactly what it is. It's because the DNA is damaged, and once it's become damaged as a result of the what you call initial insult, in this case the initial actually mutation, then the nuclear material becomes very fragile. So when it tries actually to replicate, it's going to break down, if you will. And that's really what's going to give rise to those abnormally shaped, very abnormally shaped kind of mitosis. Now you see also the very large pleomorphic cell. So now, you will see that we're starting to get into what you call in a gray zone. Like I told you, what is the first feature of the tumor? That all the tumor cells will look the same, right? This is what you call monoclonal population. But in this case, you're not really seeing, you're seeing pleomorphism. That's again because when the tumor becomes, very anaplastic in nature, you will see that, those cells will not even actually be truthful or be faithful to their mother, stem cancer cell, if you will. They will start to take all kinds of shapes because control is getting weaker and weaker as the tumor is getting more anaplastic. And that's exactly what's going to happen here, is that you will start to see cells that have very variable, very different, wide difference in shapes and sizes. Example of that, for example, the multinucleated giant cells that are taking a cribriform pattern here. But if you see within the cytoplasm, you will see the multiple nuclei in each one of them that resulted from the fusion of the original tumor cells. Rate of growth. When it comes actually to how a benign tumor grows, you will see that it is slow growing. So I mentioned to you that there are actually benign tumors that are aggressive, right? That maybe actually are on the on the more active side than others. Even those tumors, when it comes to their ability to grow, it will be far limited when compared to the most well-differentiated malignant tumors. So in this case, you will see that the most well-differentiated malignant tumor is going to give rise to a mass that is much larger than the most aggressive benign tumors. Did you guys get what I'm saying? So in terms of their ability to grow, it's going to be, there's not going to be any problem actually in distinguishing the two of them. This is one. Two, when they grow, they are going actually to grow in a very well-behaved pattern. They are not going to grow by infiltration into nearby tissue. They are going to grow by expansion actually of the tumor mass. And as a result of that, there will be compression of nearby tissue that may result in the formation of a capsule surrounding that tumor. Whereas the malignant tumors, they are going, because of their very powerful genetic mutations that will allow them to grow very fast and move much faster than the benign tumor cells. They are going to grow and give rise to these tumor cells that are going to percolate into nearby tissue. So their way of growth is not going to be actually in a form of an encapsulated tumor mass, rather in the form of actually infiltrative tumor mass. They are going to send tons of tissue in nearby structures. So as a result of that, they are not going to be surrounded by a capsule. Rather, they are going to have actually, you will see that when you try to shell the tumor out, you're going to have a problem. Why? Because the tumor has not grown in an expansile mass-like fashion. It has grown in the form actually of an infiltrated pattern. In terms of mitotic figures, you will see that it is much less in numbers when it comes to tumor. When it comes to benign tumors, and it is normal in appearance, and we have seen actually how the mitotic figures look like in malignant tumors. There will be a lot more actually mitosis with malignant tumors, and one of the things that are going also to be an indicative of the very powerful ability of the malignant tumors to grow is the presence of areas of necrosis and hemorrhage. Areas of hemorrhage will be as a result of the fact that there is a very brisk breast development of neoangiogenesis networks, and those neoangiogenesis vessels are very leaky because they have not actually sealed, the gaps between the endothelial cells, and as a result of that, they will start to leak blood, from them, showing up on the gross morphology. When you look at a malignant tumor mass, you will see that it is much bloodier, way bloodier than a benign tumor that will lack that ability. On the other hand, you will see that, that could be attributed to the growth rate of the malignant tumor cells, is the fact that those tumor cells have, such a very powerful ability to grow that they will outstrip the ability to build new blood vessels. So there's so much growth that it will actually eclipse any kind of blood vessels that are getting formed at that point in time. As a result of that, there will be a large swath of the tumor mass that are going to suffer from ischemia. And that's going to show up in the form of necrotic soft regions within the malignant tumor mass. Did you guys get that? Okay, good. All right, here's an example of the mitotic figures that could be seen actually, in this case, between a normal colonic epithelium versus an adenoma, a colonic adenoma or a polyp of the colon. So you can see actually that, the mitosis in this case, if you go in higher power, it will be limited to the most basal layer of the mucosal glands. Now, when it comes to adenomas, benign tumors, you will see that there are far more number of mitosis, and the mitosis is not limited to the most basal layer. Rather, it becomes even in the upper layer. You can see that, right? Where the point are. So they are in the most superficial layers. That's an indicative of a more robust, ability to divide. That's even seen in a benign tumor, in this case a polyp, compared to a normal mucosal glands. Here's an example of the abnormal mitosis that we talked about. Some of them what we call tripolar, some of them a smudge cell. The cell is completely gone. Again, look at this, what you call a star, shaped, mitosis. Again, why is that the fact? Because of the fact that the genome of the cell becomes very fragile as a result of the initial insult that has happened in that cell. Now, locally invasive versus, in benign tumor versus malignant tumors. So you will see, even though it's mentioned here, do not invade or infiltrate, actually, I would think that probably, they will not metastasize. That's probably really the golden rule that you can use. But in terms of invasion and infiltration, again, like I mentioned to you at the beginning, it's not really cut in stone. There are some tumors that are benign, that are known to be aggressive, that may actually destroy nearby structures, such as I mentioned to you, osteoclastoma, or the other name for it is the giant cell tumor of the bone. And there are others actually that may show up the same. But the majority of benign tumors do not invade or infiltrate. Rather, they are going to be sitting in their own shell, in their own capsule, minding their own business, going nowhere, invading or infiltrating nothing that is near. And they are going to be, well demarcated. Why well demarcated? Because either they have a capsule that grows, that have grown with them, or they are going to develop a capsule by the fact that they are going to compress nearby tissue that will be surrounding them in the form of a capsule. As a result of that fact, regardless if the capsule is growing with them or it's developing from nearby compression of tissue, the end result will be that as a surgeon you will have much easier time dealing with a benign tumor because you may shed it out with the capsule in one piece. You won't be able to do that with malignant tumor. The reason for this is that those tumor cells' ability to divide, invade nearby tissue and go through neighbors, if you will, neighboring tissue, is going to result in a very irregular kind of border. So surgical inoculation is impossible. So what you need to do, you need to either actually take the organ in one piece. For example, if it's a stage 1A in the lung, you take actually the lobe where this is arising from, hoping that it has not gone to the blood and has not given rise to any kind of metastasis. Or actually you have to, if you don't want to do that, if you want to preserve the organ or whatever left of the organ, you may actually shave a wider margin of resection, what you call a larger margin of resection, and that's where pathology and frozen section diagnosis is going to play. So you keep shaving until you reach a clean margin of resection. That's going to actually tell you that you have avoided any kind of extension of the tumor cells, the malignant tumor cells into nearby tissue. Now, the ability of tissue to resist the invasion of a nearby malignant cells is different, depending on the tissue. We know that some tissues resist that, including, the cartilage, including the elastic tissues in arteries. It is known actually that it is much easier to go through venous veins than to go through arteries. The reason for this is that the venous wall is thinner than the arterial wall. Here's an example of a benign tumor. Benign tumors, as I mentioned to you, the leiomyoma, even though this one has reached a large size. So in this case, when you examine it, you have to be very careful about sampling these tumors. We have a rule in pathology. You sample one section per centimeter. So let's say that this is actually, let's say 6 centimeter in maximum diameter. You sample in 6 sections from this tumor. And you look very carefully for any kind of sarcomatous change, because leiomyosarcoma may arise in tumors that big. When you see a tumor this big, you have to always ask yourself, that means actually that those cells have much higher ability to grow than the cells of this smaller leiomyoma. When that happens, you have to wonder if this is actually a malignant leiomyocyte versus a benign leiomyocyte. So in this case, it is still actually within the boundaries. You don't see any features of necrosis. You don't see any kind of softness, or actually when it comes to morphology, the necrosis is going to appear in the form of depression in the surface or loss of tissue. So you will see a depression that used to be tissue that become necrotic and then disappeared as a result of the work of the macrophages. Now, when it comes to those actually tumors, you can see that they are limited in size. That's a good indication of their actually benign nature. Also the fact that they are encapsulated, they are devoid of any kind of hemorrhage or necrosis, and they are well behaving. They have not, they are not really invading any underlying tissue. All of those are features of benign tumors. Here's another example of a benign tumor, in this case arising in the liver of a young female who was on OCP, oral contraceptive pill, that is linked actually to the development of hepatocellular adenoma. So in this case, you will see that this adenoma, again, well behaving, well circumscribed, minding its own business, does not giving rise to any kind of invasion or infiltration in nearby tissue, no areas of necrosis or hemorrhage within the tumor, no breach of the capsule surrounding this tumor. All of those are features, of benign tumor mass. Whereas, if you guys recall from the opening of the lecture, you will see that the border of these tumors are very irregular. Do you agree with that? All right. Then too, it is hidden in the fat, correct? And then it is pulling down the nipple. Okay. The size of the tumor mass is pretty large. All of those are indications or suggestions that this will be malignant tumor mass. Now combine this with metastasis and it will become a breast cancer right off the bat. The most solid, the most gold standard, most important gold standard when it comes to diagnosis of malignant tumors. All right, so benign tumors, for the most part, they do not metastasize. For medical school, I guess this is the only thing that you should keep in mind. Now, malignant tumors, on the other hand, they metastasize pretty frequently. Most likely, they are going to metastasize. There are, more exceptions to the rule when it comes to malignant tumors not metastasizing than to benign tumors metastasizing. All right, so most important feature to differentiate between benign and malignant tumors, and how does the invasion happen through lymphatics, blood vessels, or body cavities by the tumor. Here's an example of metastasis from a malignant tumor. In this case, it came actually from the colon. So in this case, you will see that the tumor mass are going to gain tumor cells. The colonic adenocarcinoma tumor cells are going to gain access to the portal circulation, going with the flow into the blood and into the liver. In this case, giving rise to this what you call a shotgun appearance, or a pump shot, shotgun appearance. or in American jargon, they call it in the British, more bourgeois, more sophisticated. They call it cannonball appearance. Much better than the Arnold Schwarzenegger holding a cannon in his hand, right, and shooting it up. In this case, you have this multiple kind of metastasis. Remember that always metastases are multiple in nature. Why is that the case? Why do you think metastases are always multiple in nature, whereas primary tumor is always, most of the time, majority of the time, it is going to be a single tumor mass. Especially, for example, when it comes to the liver. Exactly, because each cell that is actually a tumor mass may actually is what you call a project of a metastatic nodule, right? Each one of them may eventually end up actually forming a metastatic nodule. All right, so now just a recap. So benign tumors for the most part are well differentiated, but you don't use that for distinction because the name itself, when you say this is a fibroma, you're saying this is a well differentiated tumor. You don't say well differentiated fibroma. You reserve that. You reserve the well differentiated, poorly differentiated, or moderately differentiated for the malignant tumors. They do not metastasize for the majority number of times. They grow slowly. They attain a very small size because their ability is really very limited when it comes to division, and they tend to be encapsulated. On the other hand, the opposite exactly will happen when it comes to malignant tumors. They have a much higher ability of invasion, metastasis, less differentiated than benign tumors. Anaplastic cells usually are there, and they are aggressive and rapidly growing, and usually they attain very large sizes. Here's an example of that. One picture gives it all, right? Look at this. This is a benign tumor arising in the wall of the biometrium. So you will see that actually the tumor mass first is small. 2, it is encapsulated. 3, devoid of any kind of necrosis or hemorrhage. 4, it is not invading any nearby tissue, correct? Minding its own business. 5, they don't give rise to any kind of tumor cells that will gain access to the circulation. So when you take a section of this, you will see that the tumor cells very much look like the smooth muscle cells of the myometrium. On the other hand, this is a leiomyosarcoma, a malignant mesenchymal tumor arising from smooth muscle cells. You will see that it has gained a lot of size. 1. 2, as a result of the fact that it has gained a lot of size, areas within the tumor have become necrotic. And you see also a lot of hemorrhage. Why? Because it is very robustly profused with blood, with blood networks that are forming anew. Then you will see that it is not surrounded by a capsule. Rather, it actually follows an infiltrative pattern of growth. 4, again, the size, the fact that it has attained a very large size. And 5, that it has given rise to actually tumor emboli that is in the vein of this, that will go into the circulation, go with the flow, and pretty much anywhere and everywhere in the body. You take a section of this tumor, and you will see that the cells will not look like anywhere near a normal smooth muscle cell. And rather, they are going to look cuboidal. They are going to look, have NC ratio, a regular nuclear border. Some of them have nucleoli, and so have a very high, chance that you may see mitosis when you are examining, and especially abnormal mitosis when you are going through examination of the sections of this tumor. All right, so metastasis. What do we mean by metastasis? Simply the spread, the break up actually of the tumor mass and gaining access to. One more minute. Okay, so it will gain access to the vasculature, whether it is lymphatics or actually blood vessels, whether arteries or actually veins, or it may break and spreads directly through body cavity, and that usually is going to need the presence of a liquid in that cavity or a fluid in that cavity. For example, what happens if you have a tumor, a malignant tumor that is arising on the surface of an abdominal visceral structure. You will see that when those tumors break up from the tumor mass and gain access to the peritoneal fluid, they are going to be taken by this peritoneal fluid and they are going to get implanted through the abdominal cavity. That's what is meant by direct extension of the tumor mass through the body cavity. And in terms of why do we need to worry about metastasis? Because of a lot of times, the presentation will be in the form of metastasis. Primary tumor would not really have caused any kind of, any significant kind of presentation, or the patient would have dismissed it, and the patient is presenting with the metastasis, symptoms. That could be really anything depending on where the metastasis have happened in this patient. Let's stop here, and tomorrow, inshallah, or the day after tomorrow.